Good Friday afternoon, everyone, and welcome to the Critical Partners Emergency Management and Healthcare Coalition's webinar. My name is Travis Cryan, and I am the Vice Chair of the IAEM USA Healthcare Caucus. We thank you for joining us for today's presentation, and we hope that you come away with a new perspective on the partnership between these two organizations. Today's presentation is hosted by the International Association of Emergency Managers. We have more than 6,000 members worldwide, and we're a nonprofit educational organization dedicated to promoting the principles of emergency management and representing those professionals whose goals are saving lives and protecting property and the environment during emergencies and disasters. Specifically, the Healthcare Caucus is here to represent emergency management issues unique to the hospital and healthcare setting, with a purpose to provide emergency managers within the healthcare arena a voice on a national and international scale to ensure that their needs are being addressed. Specifically here, just this week, we've been engaging with members of the Senate and other members of Congress on the PAPA reauthorization that funds a lot of the programs that we work with, specifically ASPR that we're working with today. Also helping us promote this webinar is the Association for Healthcare Emergency Preparedness Professionals. It's a group that was formed in 2014 to provide healthcare preparedness professionals with the best range of strategic, educational, and operational networking resources available. So it's a great group. They have a great educational purpose, and we are extremely excited to be working directly with them on several initiatives right now. More to come on that shortly. We have a great group of panelists today. First, we'll have Melissa Harvey, who is the Director of the National Healthcare Preparedness Programs at Health and Human Services Assistant Secretary for Preparedness and Response. She's going to give us an overview of the HPP program from the federal perspective. Then we're going to narrow in just a little bit closer, and we're going to talk to Will Ray, who is an Assistant Director from North Carolina Emergency Management. He's going to talk to us about how healthcare coalitions are structured in North Carolina and how they engage with emergency management at the state level. Then we'll take an even closer look with Sue Leffler, who is the Director of DeKalb County Emergency Management in Georgia, and she's going to talk about how their emergency management organization works closely with their local healthcare coalition. Then we'll wrap it up with an opportunity for some questions. If you have questions along the way, feel free to put them into the question box or the chat box. We will be monitoring that, and we will try to get those answered as we go. Without further ado, I'm going to push the presentation over to Melissa Harvey from ASPR and let her introduce herself and jump right in.
Good afternoon. Thank you so much for joining. We're excited to partner with the IAEM and AHEPP today, and thank them very much, honestly, for suggesting this webinar, because we've always felt that it would be a wonderful opportunity to speak with the emergency management community about the benefits of joining healthcare coalitions and really share with them the unique work that healthcare coalitions do, and honestly how it can be really helpful to all of you during both the planning phase as well as the response phase of an emergency. So I really want to thank our colleagues for pulling this together, and thank all of you for joining. I think we're in for a treat here with all the panelists who are on, who can speak to certainly the state and the local levels of and the benefits of healthcare coalitions. But I wanted to start off first by describing really what healthcare coalitions are, at least from the federal perspective, although you'll hear some examples of those as we go through the entire webinar, and explain a little bit about trends nationally in terms of what we see with healthcare coalitions. So moving forward here. Great. So the Hospital Preparedness Program is the primary program that funds healthcare coalitions. It is a cooperative agreement program that the federal government administers and provides to the 50 state health departments, as well as directly funded cities of Washington, D.C., New York City, Chicago, LA County, and our territories and freely associated states. And it's the only source of federal funding that provides basically resources to ready the healthcare delivery system. We do this, used to do this by directly through our awardees, our recipients, having them fund hospitals, but we realized over time that we needed to have a much more comprehensive approach to healthcare readiness by bringing not just hospital partners together, but all of our healthcare partners, everything from nursing homes, dialysis facilities, other kinds of outpatient types of clinics, because we recognize that when they are not ready, the burden often falls on the emergency department and the hospitals, which is where those patients often evacuate to or show up at the front door of when an emergency happens. So we pulled healthcare coalitions together, which are groups of, again, those healthcare organizations, as well as the critical partners of public health, emergency management, and EMS, to have them begin working together both in advance of an emergency, sharing plans with each other, drafting plans, exercising and training, and certainly responding together. And we've found that it's been very beneficial for these partners to get together, describe their the hazards that they all see in their communities, the objectives and the priorities for them to address, and then the best ways for them to prioritize not just their funds, but the activities for the year. I think we all think that there is probably no shortage of work to do, and it can't all get done each year, so really need that prioritization to happen. We do promote a sustained national focus on, again, improving patient outcomes. That's what makes the hospital preparedness program different from many of the other federal grant programs that are out there, including UASI and the Public Health Emergency Preparedness, or the SEP program at the Centers for Disease Control. HCP is really about patient care and the healthcare delivery system. We are not about kind of prevention and laboratories and epidemiology and some of those more public health types of activities. We are funded this year at $265 million. You'll see the rather unfortunate trajectory of our funding at the table on the right-hand side of the screen, but it has somewhat turned the corner and is maybe starting to go back up. But we have taken about a 54% decrease since the height of funding back in 2003 and 2004. And as I did mention, we have our 62 recipients, but those recipients, those 62 awardees, fund 361 healthcare coalitions across the country. And inside of those coalitions are nearly 35,000 healthcare coalition members. And these members are not individual people, but rather are, again, those organizations and those agencies that come together to work together. For those who it's easier to see things kind of more graphically, this is a graphic depiction of a coalition. We require through our funding that all of the coalitions, those 360 plus coalitions, have what we call 4 core members. And you'll note that emergency management is one of them. So in order for one of our awardees to give funding to a healthcare coalition, that coalition must have at least 2 hospitals, emergency medical services, emergency management agencies, and local public health departments inside of them. Now, many of the coalitions have other types of members as well. I mentioned a lot of those outpatient facilities and skilled nursing facilities. We really do let the coalitions determine, outside of those 4 core members, which ones they want to include, because every community does look different. Not every community has academic institutions or robust volunteer programs, but certainly if those are around, really the more partners, the better, as long as there's a role and a clearly defined governance structure for that coalition. So to give you an example of what we call our penetration rate, or our membership participation rate, we have 93% of the nation's acute care hospitals currently in those 360 plus coalitions, about 91% of public health agencies, 62% of emergency management organizations around the country, and 39% of EMS. Now, I don't think with emergency medical services we'll really ever get toward that 100%, since there are just so many various different types, whether it's air and ground and 911 versus interfacility transport between healthcare facilities. But we certainly would love your assistance in boosting up the participation of the emergency management community and healthcare coalitions, because we recognize that while our healthcare facilities working together provides a critical service to emergency management in terms of your situational awareness of what's happening inside of the healthcare sector. And in some cases, the healthcare sector sharing with each other resources that emergency management often can't procure, those very specific healthcare resources that really only can come from healthcare suppliers and distributors and healthcare facilities sharing with each other. We do recognize that emergency management plays a very critical role when it comes to kind of keeping those healthcare facilities running during a disaster, everything from prioritization of electricity, fuel, water, those very critical services that it almost doesn't even matter if you have ventilators or other kinds of equipment. If you don't have those major services, those facilities would need to shut down. You'll see on this slide many other types of really healthcare facilities and partners that, again, are what we don't consider to be the core members, but really do play critical roles, especially those that we really want to try to help them be able to sustain their operations so that they don't need to evacuate their patients to healthcare facilities, inpatient facilities, when all of the those who were impacted by the emergency, such as those who got injured from whether it was a natural disaster or if it's a pandemic from a emerging infectious disease outbreak, are going to need hospitalizations on top of all of the routine healthcare incidents that occur every single day. We always say that heart attacks and strokes don't stop just because a hurricane's coming, and so those hospitals really do need to find surge above and beyond what they're used to caring for. So just like FEMA, we have a set of capabilities, and our capabilities are actually crosswalked with FEMA through our grant coordination initiative, and you can find that both on our website as well as on FEMA's website. And they are crosswalked as well with the public health capabilities from CDC. And we have 4 capabilities, and the 4 that you see here on the screen. The first is the Foundation for Healthcare and Medical Readiness. And the whole genesis behind this capability is the idea that we need to build and set up our coalitions as a foundation to be able to do almost the rest of these capabilities. So it's the idea of making sure that the borders of the coalition really align well with trauma patterns and other healthcare delivery patterns. I will say we've had a huge shift in the number of coalitions over the years, and some of that is because many of our partners have recognized that while it might make sense to have emergency management and public health align with county government or specific emergency management regions, the healthcare system really works very much on how, in a disaster, on how it works day to day. And day to day, it works based on its own naturally defined healthcare patterns that don't really pay much attention to county borders or other kinds of geopolitical borders and boundaries. So we know that creates challenges for how public health and emergency management kind of fit into these coalitions, because there may be, for example, 3 or 4 emergency management entities or more that really are covered by a healthcare coalition. So it requires kind of even more coordination than if it was set up by political borders. But at the same time, we've tried that and found that working it based off of natural healthcare delivery patterns tends to work much better. The second is on healthcare and medical response coordination. And what I will say, this sometimes gives a little bit of heartburn to our ESF8 partners who always say, wait, coalitions don't respond. The ESF8, whether that's the public health department or emergency management who runs that in your jurisdiction, they are the primary responders. And we do agree with that. ESF8 is the primary responder in all local and state communities. But at the same time, while our coalitions are not expected to do incident command and control, they do coordination very, very well, and they do share information with each other in a way that can come up in a nicely packaged set of materials and information to you, so that you don't have 210 nursing homes calling your ESF8 desk at your EOC, or you don't have 157 hospitals individually calling you, and you can really figure out through that coalition what the overall greatest needs are, as well as what the coalition has prioritized both for response and planning purposes. The third capability is the continuity of healthcare service delivery, and that is really exactly what it says, how we make sure that healthcare can continue to provide services, and that's not just hospitals, but again, outpatient centers as well, even in the face of an emergency. So this capability takes into consideration things like supply chain issues, sheltering in place, evacuation of healthcare facilities, and then the coordination of how that would all work during an emergency. And last but not least is medical surge. And this is obviously probably the largest capability of all of our 4 capabilities. And it really breaks up the capability into capacity, which is just, again, providing for sheer numbers, versus capability. And we switched it that way in the latest version of the capabilities after the Ebola outbreak, when we learned that even just 2 handfuls of patients in the United States can really bring the health system to its knees. So that wasn't really a capacity surge as much as it was a capability surge, because we didn't have prior to 2014 and 2015, we didn't have the real true capability, knowledge, and expertise on what would be required for patients like that. But again, it wasn't a surge type of event where we would expect to see thousands, potentially tens of thousands of patients. So I wanted to share with you a few stories of where our coalitions have been very successful in the past. And you can always find more of these, probably perhaps even some from your own states and communities, at the web link that's at the bottom of this page. So we do ask our coalitions to stand up during planned events. And the first example is of the Republican National Convention, where we have a very sophisticated coalition in Northeast Ohio that has some inventory of supplies. And they really were working very closely with their public health and emergency management partners on how they would distribute those supplies and coordinate information sharing for the over 20,000 convention visitors should something have gone wrong at that convention. Even if it was a natural foodborne outbreak and not necessarily a terrorist attack, that would have been a tremendous surge on the healthcare system. And they worked very closely with not just the local and state partners, but also the federal partners in terms of the military and others on how patients would be evacuated if the entire region could not support the event. The next, many of you are probably familiar with Hurricane Harvey, where we again have a very sophisticated coalition in Southeast Texas. And that coalition effectively coordinated more than 1,500 patient movements, as well as enabled a number of the healthcare facilities in the Houston area to shelter in place in ways that they might not have been able to if the coalition was not there. So when a hospital had to evacuate, they basically faxed their patient list and the patient conditions to the coalition, which worked with the receiving facilities to find beds for each of those individual patients and the transport partners to figure out how they would actually be moved. And then they faxed that back to the hospitals, who didn't have to worry as much as they were taking on water about finding places for their patients, and instead had the coalition doing that at their level. And last but not least, during a train derailment in Washington State, we had another one of our very sophisticated coalitions in the northwestern part of the state that really did a great job working on patient tracking and patient reunification with families, since again, patients had to be distributed in some cases fairly far from where the incident took place to be able to accommodate all of them. So in terms of those capabilities, I wanted to give just a little bit of a progress report on how they're doing. And 83% of our coalitions are really have completed sort of what we call capability 1, that readiness capability. And 71% have completed that response coordination capability. 69% are making some pretty good progress on continuity, and 71% on surge. The area where we're having, I would say, some of the toughest challenges, though, are we have great participation from our hospital emergency managers, and I've really enjoyed working with the IAEM and AHEPP on engaging that group. We're trying to gain some better engagement with the executives, the CEOs and the COOs, because we're all of us on this phone are probably familiar with the fact that that group tends to like to take a place in the incident command structure when an emergency happens. But if they haven't been involved in the planning, nor have they been involved in the exercising, many of them, A, don't even know they have a coalition that they're a part of, and B, don't really know how that regional coordination works. So we're trying to do a better job engaging those coalitions by requiring, those executives, by requiring that they participate in hot washes of the HCP required exercises each year. So we have a new funding opportunity announcement that's out on the street, and I just wanted to let everybody know that, because I'm sure you'll be engaged by your healthcare coalitions to help meet some of the requirements. I'll quickly go through some of those. We are encouraging additional healthcare coalition membership in the form of blood banks and laboratories and other types of entities that we found to be very critical, particularly during these no-notice events, including mass shootings. Our coalitions are led by various different types of entities, with about roughly a third of them being led by either state or local public health, a little more than a third now being led by either state hospital associations or a lead hospital themselves, and then another third led by a variety of different entities, including 501c3 or not-for-profit organizations, universities. We have a couple led by councils of government or medical control authorities. But we are requiring all coalitions to have at least one what we call co-lead hospital. So even if it's led by the public health department or the emergency management agency, that there's a co-lead hospital designated, and that every coalition now must have at least one full-time equivalent, likely paid for by HCP, so that there's someone this isn't just a volunteer job or another duty is assigned, but someone who's really there to make sure they can turn the lights on the minute an emergency happens, and that they can do that coordination of the planning and the planning for the exercises. We are renewing our focus on encouraging hospital partnerships with the National Disaster Medical System. We learned during the past 2 hurricane seasons that it's a whole lot easier to have memoranda of understanding in place with NDMS and healthcare facilities before an emergency, not as we're trying to literally move patients to those hospitals during a federal patient movement mission. And we are also encouraging those hospitals to work very closely with their federal coordinating centers on exercises and information sharing exercises specifically. Number 4 talks about Healthcare Coalition specialty surge annexes. So this year currently, by the end of this month, all of our coalitions will have developed a response plan. And that response plan is going to look very different for each of them. For all of them, it should be talking about sharing of situational awareness and what types of essential elements of information are required to be shared. Some of them are going to go a little bit further as far as how they're going to share resources with other healthcare partners, healthcare resources specifically, but not all coalitions do that. Not all of them vet and share resources. But we are asking for the next 5 years is that each coalition develops a specialty surge annex, and the same one each year, with this next year beginning with pediatrics, to make sure that we have an idea of how these coalitions would distribute pediatric patients for what is often a very limited resource in terms of pediatric specific beds. Next year will be burns, and then the following 3 years are infectious disease, chemical, and radiation. We're also asking every coalition to complete a coalition surge estimator tool. And this is really to help us figure out, above and beyond the regular routine hospital beds, how much can a region surge? So when you have an event like the 1 October mass shootings in Las Vegas, where those hospitals did a phenomenal job identifying additional space to place patients, whether that was through their PACUs or other kinds of units that are not used routinely for more types of inpatient care, we're asking them to really estimate that, aggregate it at a coalition level, and send that to the federal government. And for some of you out there who are from much more rural or geographically isolated communities, you may be wondering how coalitions can help you. And we have heard from some of the those rural communities that coalitions in some cases can be more helpful than even in urban areas there, because they have to work with their partners every day to transport patients that show up at critical access hospitals that just can't be handled by those hospitals. And they really have to work much closer with EMS, who do much more long distance type transports. But we are also providing flexibility for geographically isolated areas in the event that they need to be able to focus much more on their hospital, and rather than a coalition, be able to do that. So because Ebola is in the news quite a bit lately, we do have a very terrible outbreak in the DRC over in Africa that's very different from our 2014-2015 outbreak in West Africa, in the sense that the security situation is really preventing the global community from mounting a very effective response. I did just want to touch on what has been built on Ebola, for Ebola since the last outbreak. So every region has what's called a regional Ebola and other special pathogen treatment center. And these 10 regional Ebola treatment centers are just as capable as Emory and Nebraska were when they began receiving patients, when they were really the only 2, aside from NIH, Ebola treatment centers at the beginning of the last response. We have Emory in Nebraska and Bellevue going out annually and doing site visits to all 10 of these facilities to make sure that they are as ready, not just in terms of safety and in terms of being able to make sure that their providers don't become ill, but also in terms of training the clinicians there on how you actually care for a patient with Ebola or another type of disease that requires biocontainment. We have 69 other what we call state and jurisdiction-based Ebola treatment centers whose capabilities may not be as great as the 10 regional centers, but many of them are still highly capable of caring for at least one Ebola patient at a time. And then last but not least, we have 178 assessment hospitals, at least one in each state, that can do collect the lab samples and care for a patient for up to 96 hours until it's confirmed that they do indeed have Ebola and would again be transferred to one of these higher levels of care. I just mentioned Emory in Nebraska and Bellevue, but they have collaborated to combine themselves for the National Ebola Training and Education Center, where they do site visits and peer review and assessment for all other types of healthcare facilities in the network that I described above to make sure that they are indeed ready. They have a website with a tremendous amount of resources, including those for what we call frontline healthcare facilities. And that's really any healthcare facility in the country that may just have a patient walk up to them complaining of fever or other types of symptoms and a recent travel history. And then there is a very strong potential that within minutes you could have an Ebola patient on your hands. We've also established a training center at the University of Nebraska that can quickly be turned on a dime into a mass quarantine center where up to 20 patients at a time can be quarantined for up to 30 days so that we can avoid some of the challenges we had during the 2014-2015 outbreak when high-risk travelers had to actually be quarantined, not just monitored, and now we have actually a place to do that. I mentioned the NETEC and their website, and I highly encourage you to at least go on that if you haven't before to see the types of technical assistance that can be provided both on the website and in person. And certainly the NETEC is willing to liaise both on the phone and consult in person with anyone that is interested in receiving a site visit for readiness. And I wanted to mention one last thing that may be of interest to those on the phone. HPP, in collaboration with FEMA through their Center for Domestic Preparedness, has established a course down at the CDP in Anniston. And this is where we bring healthcare coalitions as a leadership team, so 9 different individuals from each healthcare coalition. We bring 3 coalitions at a time down to Anniston, where they learn all about basically how to plan effectively and respond together and how to develop those leadership skills to really be able to move their coalitions further along in the planning and response process. For those who have been down to Anniston, what we found in some ways is that even more so than the course, the being down there and actually being there for 3 straight days with your team, both day and night, really provides that kind of bonding experience that has really enabled a much more successful response in some of our coalitions that have been down there in the past. And there are various different types of continuing medical and continuing other kinds of education credits that are available for those. So with that, I'm happy to pass it on now to our next speaker and pass it back to Travis. Thank you.
Thank you, Melissa. That was a great overview. So that's the federal perspective. Now to see the work that's being done at the state level, we're going to move to Will Ray and let him talk about how things are being done in North Carolina. We also picked Will because not only is he the Assistant Director for Emergency Management at the state level, he came to that office after being the HPP Program Manager for North Carolina. So he's intimately familiar with both sides of this equation. Will, it's all yours.
Thanks, Travis, and thank you to Melissa and Sue and the others on the phone. We really appreciate the opportunity to talk to folks this afternoon. And before we get started, on behalf of our Secretary of the Department of Public Safety and our Director of Emergency Management, we are really excited and fortunate to be able to talk about our ESFA partners, which we're not biased in any way, shape, or form, but we think we have some of the best in the nation. The intent today is really to talk through briefly what our structure is in North Carolina, how we leverage partners, what the healthcare preparedness program in North Carolina, how that is structured, specifically some of the capabilities that the healthcare coalitions bring to the table, and then provide you just a quick snapshot of what some of that looked like during Hurricane Florence, which was our most recent major disaster. Broadly, as we talk about emergency management in North Carolina, our entire goal is to support local jurisdictions as they prepare for, respond to, and recover from major events that may overwhelm their local capacity. It is something that is at the core of everything that we do within our state emergency management, within the tiers that we have established. The focus really is, again, how do we help that local community, that local jurisdiction, hopefully mitigate some of the impacts of events, but when needed, to be able to respond and then recover well. Here in North Carolina, we have some state legislation that defines broadly what our state emergency response team is, and I do want to stress, as we talk about response to Florence and response to other events that have impacted North Carolina, this is not focused on the Division of Emergency Management, although we have great staff and great folks that work here. This is really about our state emergency response team partners. And here in North Carolina, our public health and medical partners are a major piece of that success, whether it's during blue sky days when they're working on preparedness functions or when they're heavily engaged in response and recovery actions. Our healthcare coalitions in this state really help to bridge the gap between our side of the house in emergency management and healthcare, which is, as everyone knows, a very critical infrastructure here in our country, but is also a private sector function. And they do a huge lift when it comes to really bridging that gap. How are we structured here in North Carolina? So the Office of EMS here at the state level, which is within our Department of Health and Human Services, oversees the management, implementation, and operation of the healthcare preparedness program for our state. They have staff at a state level, which represent the program here at our state emergency response team. And then during response, this flips over to really being our ESF8 operational arm across the state and into some of our impacted jurisdictions. They are really a huge help when we talk about the interconnectedness of healthcare and the layers and overlaps and the potential ripple effects should one thing happen locally, how that's going to impact the ability to care for patients and people in need. Again, as I've said, they are really a huge linkage to making that successful. The way our healthcare coalitions are structured are through a subrecipient model. So we have leveraged all of our level 1 trauma centers in North Carolina, as well as a couple of our level 2 trauma centers, and have a contractual agreement with those hospitals to implement the HPP, the federal HPP program, as well as maintaining a operational component, which we'll talk about later in the briefing. Broadly, the goals of our healthcare preparedness program, as you look across statewide, you have them here on the screen, and these are really the 4 buckets that mirror what the federal guidance is, but we really feel like regardless of the day, the event, changes in federal guidance that may come down the road, these are the 4 buckets that we really feel like our healthcare coalitions and our healthcare preparedness program at a state level really are focused on and really support the further development of. In blue sky days, here's some examples just kind of what each of our coalitions are working on. Each of our 8 coalitions have full-time staff as well as part-time staff that are based at those lead hospitals with the responsibility of outreach and preparedness activity on a day-to-day basis to the range of stakeholders which you heard Melissa already talk about in the previous brief. But this is everything from emergency operations plan development, training and exercises, development of response plans and mission ready packages, and then coming alongside impacted healthcare organizations when we talk about recovery and resiliency. And one of the things we've done on the emergency management side of the house is as we implement our DHS and FEMA grants with our local emergency management programs, what we have done is integrate some local requirements for interaction and engagement. So our local emergency managers are able to get credit for their grant program requirements by engaging in some of these exercises, in assisting with some of the plan development, in participating in training or providing training to our healthcare coalition. So over the last couple of years, we've really tried to leverage some of the common items that are across these different federal grant streams. So again, this is more blue sky. This is day to day. This is what are the staff in the office or on the road engaged in and doing. And when we flip into the response mode here in North Carolina, we have a very broad state medical response system, and we'll go through some of the components here in a second. But this is a part of the contractual agreement with our healthcare coalitions that during an incident or event that impacts either a local jurisdiction, their given region, or a statewide event, that there are certain assets, resources, and capability that they're able to bring to bear to really support an overwhelmed healthcare infrastructure in the state. So as we talk about operational missions that each of our coalitions support and are constantly maintaining and building out and trying to refine some of their capacity in, we have a state medical support sheltering model, which you'll see some pictures of here in a couple of slides, where we also focus on maintaining broadly some field medical care, field medical station capability, whether that's to replace an emergency department that's freestanding or that's more for an alternate care facility model. We look to our coalitions to really help support patient movement, and that's everything in Blue Sky from planning and process development to actual patient movement during an event, as well as coordination of beds and all of the everything that goes around transferring patients in between facilities. We also have an asset that is specialized here in North Carolina, our mobile disaster hospital, which is really intended. We look at our coalitions as that first tier out. When a local jurisdiction, hospital, EMS system, that local ESF8 infrastructure is overwhelmed, we have some capabilities we can bring to bear as a state emergency response team to support that in a short term. As we look at longer term recovery or longer term ability for an impacted jurisdiction to maintain some healthcare capacity to be able to treat a population that continues to be in need or that also needs a job, to keep folks that are employed, we have this specialized asset as well. And then finally, we have the remainder of our support really falls into a broad logistical or resource support. And that's everything: light towers, generators, water purification, HVACs. We also have some pharmacy trailer capacity as well. So I want to switch gears real quick just to briefly give you an overview of Hurricane Florence. And we lived through Hurricane Matthew in 2016, and that previously was our storm of record. The storm we experienced last fall, the damage that it has sustained to North Carolina is more than Hurricane Matthew and Floyd combined. So we are still very much engaged in response and recovery to that event. It will continue for years. There are still jurisdictions that had not fully gotten back on their feet from Hurricane Matthew that were again significantly impacted during Hurricane Florence. So our activation here at a state level really started on September 7th. As we looked towards the end of that next week with landfall of the hurricane, the run up to that really focused on pre-deployment of commodities, pre-positioning of response assets, trying to work with local jurisdictions on evacuations or sheltering decisions. It should be noted this is the first time in the history of North Carolina that the governor executed some of his statutory authority and issued a mandatory evacuation order for part of our barrier islands. As we moved into some of the later dates in the storm, at peak we had over 23,000 people in our shelters statewide. We had over 800,000 power outages, and this was a 3-week activation. Again, the state EOC has been deactivated for this event, but we still have a joint field office that is stood up. We still have staff that are engaged in these impacted areas of our state and are still actively trying to assist these communities in repairing some of this damage, especially as we get into the beginning of our next hurricane season. During Florence, we really leaned on our ESF8 partners here at a state level pretty heavily. On the screen, you see some examples of some of the major missions that they performed for us for the 3-week period that we were activated. We had 4 state medical support shelters scattered statewide that treated a couple hundred patients that are much more acute than probably could have been cared for in a general population shelter, certainly more comfortably able to meet their needs a little bit better. We also had 2 field medical stations deployed to augment some local hospitals that were significantly impacted. We provided both mental health and medical support to our general population shelters. Again, we talked about some of the patient movement support, and that was everything from coordinating hospital evacuation and allocation of patients to the physical transportation of those patients from point A to point B. Their staff provided some overhead incident management support to some of the impacted jurisdictions. And then just a note for those emergency managers or state level folks on the phone, one of the things we learned in Matthew was as you have healthcare providers cross state lines, as you have healthcare facilities evacuate across state lines, not only are we concerned about federal regulatory requirements, but also state licensure. And so we learned during Matthew, and again had to implement this in Florence, we had a no-cost EMAC established between the state of South Carolina and North Carolina to allow those medical providers from South Carolina evacuating with their patients to sister facilities in our state to continue to work and function. The next couple slides are just some examples of some of the assets and resources that were deployed downrange into our impacted areas. Here you see some of the transportation and patient evacuation support that was needed. This is a shot of one of our medical shelters down in the eastern part of the state. This isn't not from Hurricane Florence, but this is an example of what an alternate care facility or field medical station may look like. Again, we're very fortunate to have a wealth of specialized transportation assets scattered across our state, housed and supported within our healthcare coalitions, from ambulance strike teams, which you see the support trailer there, and how we can quickly deploy task forces or strike teams of EMS providers and units to be able to evacuate patients quickly. We're fortunate to have a number of mass evacuation buses. And then we've talked about some of the logistical support. Obviously, our goal is, where possible, to keep those impacted facilities functioning and keeping those patients as close to or in their communities that they're from, so that, again, their outcome can be as positive as possible. We know that you keep patients as close to their support system as you can, they are going to fare much better when we move into recovery. So as much as we're able to keep those patients local, we try to do that. As we talk about the mobile disaster hospital, this is some shots of what that asset looks like. This was one of the field medical stations that was set up in the eastern part of the state to augment a small regional hospital who had lost some of their emergency department capability and needed the ability to continue to treat patients there locally. Finally, my last point related to Hurricane Florence is I do want to say, as we have a number of folks on the phone or on this webinar from across the country, I want to say thank you to many of you who sent public safety, first responders, and other support personnel and resources to North Carolina last fall to support our response to Hurricane Florence. Of the 95 total EMAC missions we had to lean on states to provide, with 35 states represented and over 1,000 total responders. Of those totals, 23 of those missions were purely ESF8, public health or medical. 356 of those responders were just health and medical. So again, we were very fortunate to have the established partnerships through EMAC and through Region 4 and some of our partnering states and regions to be able to have assets and resources come in and assist. And I do want to say here on the phone, thank you for that. So with that, that is our quick brief from a state level. I think we really see how federally the HBP program can be implemented on a statewide model to really serve as that linkage between traditional public sector and traditional public safety and emergency management with a major critical infrastructure we have in this state in health and medical. And thank you for those of you on the phone that are in public safety or are in emergency preparedness. Just wanted to say a quick thank you for what you do each and every day to support your local community. And with that, that's all I have, and turn it back to Travis.
Thank you, Will. Thank you for being a great advocate for both the emergency management process at all levels and healthcare. So with that, we will move the presentation over to Sue Leffler from DeKalb County, Georgia, and hear about the local perspective about how local emergency managers can partner more closely with their coalitions.
Good afternoon, everybody. I'm Chief Sue Leffler. I'm the emergency manager for DeKalb County, Georgia. and I'm also on the executive coalition for our Region D Healthcare Coalition. And I just wanted to say thank you so much for this opportunity to talk about, from a local level, how emergency management is a critical link with the Healthcare Coalition. I get a lot of questions from other emergency managers as to why am I so involved in my healthcare coalition and what's the benefit. And so I hope that my presentation this afternoon, I hope it's afternoon for most of you, will at least give you some insight into why it's really critical. So our Region D Healthcare Coalition covers a total of 8 counties in the metro Atlanta area in Georgia. So those 8 counties are Clayton, DeKalb, Fayette, Forsyth, Fulton, Gwinnett, Newton, and Rockdale. Just a quick bit about our coalition is our mission is to be a unified healthcare community partnership, and we want to provide integrated emergency preparedness, planning, response, and recovery activities for the metropolitan Atlanta area. And those of you, to give a little perspective about Atlanta and some of the large things we have, we just hosted the Super Bowl last year. We are a very urban area in the South. I do have the CDC in my county, as well as Emory University Hospital, Children's Healthcare, and several other large hospitals and healthcare facilities. So a little bit about DeKalb Emergency Management, or DEMA. We serve as the emergency management agency for DeKalb. Our population is 750,000 plus people with over 271 square miles in the county. We've got 13 cities in DeKalb, including part of the city of Atlanta. We also have the largest resettlement of refugees in the state of Georgia, with 5 resettlement agencies in the county, and I have over 140 spoken languages in our county. So we have a very diverse county. The mission of DeKalb Emergency Management and some of the things we do: we maintain and develop all the local emergency management plans and programs. We maintain the Emergency Operations Center for the county and all the cities. We act as a liaison, local, state, and federal authorities. We provide 24-hour coordination of resources. And basically, we work with local governments, volunteer organizations, private sector, and everybody to try and plan for disasters, mitigate activities, provide training and exercise opportunities. We're kind of what I like to think of as the Radar O'Reilly of getting things done. We no longer respond directly to emergencies, which is what a lot of people used to think emergency management did. We're the coordinators. We're the ones that try and think 3 steps ahead on what's going to be needed for a large emergency or disaster. So why should local EMA be part of a healthcare coalition? Well, everybody who's in emergency management knows that partnerships make or break you in large emergencies and disasters. So what better way to make better partnerships, meet more people, and learn your community and who's in your community than being involved in your local healthcare coalition? It brings everybody in from your main hospitals to your dialysis centers who have very special needs, and many other types of healthcare that you may not have even thought about that's in your county that are going to rely on you in a large emergency or disaster. Communication. We can't get through things without communicating. And for folks who don't know where to get information when an emergency happens, or something, whether it's a no-notice event or even something we plan for, whether it's an ice and snow event, how do they get information? How do they know what's open? How do they get their information? So it helps us communicate throughout the healthcare coalition on where to get information in emergency and who to talk to. So we also do a lot of planning, especially on blue sky days like today. We try and meet and greet and plan and talk about what we expect from each other on a local level. we've made a lot of great strides in Region D since I've been in the Healthcare Coalition talking strictly to dialysis centers. In years previous, dialysis centers used to send out a letter to us of what they anticipated we would be able to provide for them. Since inviting them to the Healthcare Coalition and meeting and talking to folks, we now have a better idea of what they need in a disaster, and they have a better idea of what we can help them get in a disaster. So we've been meeting and planning all the way from the state level down to the local level to make sure that we are able to plan and prepare better. The Healthcare Coalition does a lot of exercises and drills, some of which I'll talk about shortly. And basically, to round it off, it's when you have a real-world event happen, whether it's a hurricane that you can see coming, whether it's a tornado that just pops up, or maybe a utility failure like a large water main break. When you've made these partnerships and gotten this communication piece down and you've planned together and you've exercised together, your partners are going to be there for you when an event happens, and you're going to work together better to better take care of your community. So this is a quick view of the Region D hospitals. You can see we have a large number of hospitals with a large number of beds. The ones in yellow are the ones that are in my county specifically. These are the facility types that we have in the region, and they're listed by county. So you can see we have 19,794 beds that we're looking at. So that's a large amount of medical facilities and beds. So let me kind of hop right into one of the last tabletops that we did as a coalition. We got a large facility to host this, invited all our partners. The exercise date was November 1st, 2018, and it was basically a tabletop exercise for anybody in Region D. Basically, we wanted to test 4 capabilities. So in order to test those capabilities, we didn't do one scenario, we did 3. We might have gone a little big, but everybody got a little bit out of each of the scenarios. So our first one is winter weather, and I know some of you thinking winter weather in the South, how bad can it be? Probably haven't seen us have an ice storm that shuts things down, because I know we can drive on snow, but you really can't drive on ice. So everything kind of shuts down. How do you get facilities, everything from basic supplies, supply chains can stop, and how do we handle those kind of issues? Bioterrorism. We had the Super Bowl, so we were very cognitive of what could happen and trying to plan as best we can for the unknown. And then the simple everyday possibility of a utility disruption, whether it's a severe squall line that comes through with high winds and takes down trees and we're out of power, or whether it's, again, a water main break. The capabilities we tested were for healthcare and medical readiness, healthcare and medical response coordination, continuity of healthcare service delivery, and med-surg. So it was a really big undertaking in just one day to try and get everybody involved and to be able to see what could happen, how we would respond, how the Healthcare Coalition could assist everybody in this kind of scenario. And the key issues that we really tried to press were communication, resources and assets, staff responsibilities, and utilities. The end result was we examined strengths and weaknesses and honestly came up with some improvement plans. And I think everybody went home that day with a kind of a new worldview of what their partners can do to help them and how we're going to get through things together. So that was a planned exercise. So let's talk about real world events, especially ones that happen kind of without any notice. So what you're looking at here on the screen is in DeKalb, we had a 48-inch water main break. a no-notice event that happened, I guess it's about 3.5 years ago now. So basically, a grass cutting crew on a big bush hog hit a fire hydrant. The hydrant began leaking. It didn't cause that serious of a response. Once they started to dig a little bit, as watershed management got on the scene, they found the fire hydrant was directly connected to our largest water main in the county, which is a 48-inch main, and it was buried 25 feet underground. The main was installed in 1974 and was ductile iron and had a hydrant directly connected to it. So emergency crews, of course, responded, and the valve that they found was 20 feet deep and was not accessible. So watershed decided that they were going to try and work on it that evening, but we weren't given any notice because they thought it was just a fire hydrant leaking. So that evening, I'll say my phone began to explode as hospitals and other critical infrastructure started calling. And the more folks that called watershed quickly got overwhelmed on their dispatch. And the water pressure in and around the county went down from 90 psi down to anywhere between 10 to 20 psi. So we had a major drop in water pressure. There are only 3 main water lines coming out of watershed at that time for the whole county, and that 48 was our biggest line. So what immediately happens? As soon as I realized this was happening as the emergency manager for the county, I started making my phone calls. I think I swapped. There we go. That's better. I started making phone calls to my state emergency management agency, which is GEMA, so that they'll know we've got an issue, and as soon as I start calling for resources, they're already starting to line up resources. I called the regional coordinating hospital, all our local hospitals in DeKalb, the DeKalb Board of Health, CDC, Public Safety, and many other departments. We immediately started scheduling conference calls to get everybody in on what was happening, what they could expect, and what we were going to do about this very large damaged water main. With the EOC opened, we started rallying water tenders, 3,000, 5,000, and 8,000 gallon tankers, not just for fire resources, but they were also put on standby because at the time it was fairly warm. And I know if my hospitals don't have enough water, I want to avoid evacuating a hospital at all costs. So if their chiller starts getting low on water and shuts down, we're going to have to evacuate. And I don't want to do that. So we brought in water tankers specifically to be able to fill chillers. So we started talking to the hospitals and their engineers about how that process could actually happen from an external water source. Again, watershed started to schedule the work overnight because there's less of a demand and there's less going on in the hospitals overnight, as well as the dialysis centers and everybody else that uses water. So their plan was to begin fixing that 48-inch at 11:30 on July 23rd on a Thursday. What they found out overnight was they couldn't access the valve, so they had to stop. Water pressure, they were able to maintain water pressure from the plant coming out at an 18 to 20 pound PSI through 2/3 of the county. With that decrease, anything that had toilets above the 3rd floor had trouble flushing toilets. So now think about my hospitals that are 3 and 5 stories and how they're trying to deal with the ability to flush toilets and keep patient hygiene, not to mention sterilization procedures, etc., with this kind of water shortage. Watershed began getting sample collections to test for contamination to see if we were going to need to do a boil water advisory. They began trying to figure out, again, how are we going to manage to get this fixed. To give you an idea, there were almost 2,000 calls to Watershed on Friday, and the wait time became almost 2 hours. So the conference calls we were having with our healthcare coalition, our critical infrastructure, and others were very critical to get their information that they needed on how they could continue operation with this water shortage. We secured several tractor trailers with pallets of water and started distributing them out. Hospitals took several. They have water, but we weren't sure how long at this point they were going to be out of water. So we went ahead and started bringing in extra just to try and assist. Water tenders began moving between the hospitals, jails, and other critical infrastructures to refill chillers. I had 3 water tenders who were out and being used to refill chillers. On Friday, they again attempted to fix the 48-inch damaged pipe, and they thought they'd had it fixed, but as pressure was restored, the repair failed. And so pressure again dropped back down to the 18 to 20 PSI on Friday night. In the Saturday morning, we again had another conference call, and with the Board of Health and Watershed, we put out a boil water advisory and the information on how next they were going to repair the break in the line. The boil water advisory was declared, and we sent out code red notifications, which is our emergency notification system. Saturday PM into Sunday AM, we again continued putting information out, conference calls on our website, and talking to our partners to update them again on what we expected was going to happen and how we were going to manage this as it continued. Once you declare that boil water advisory, usually it's going to be at least 48 to 72 hours before the state assesses what's happening and then can lift if everything is clear. So many facilities were getting really close to critical mass after 2 full days of minimal water pressure, and we were starting to discuss evacuation procedures for several hospitals if we could not get this fixed. Our animal shelter also ended up closing down. Many restaurants and a lot of other things were happening all in this time period. They did reduce pressure overnight on Saturday into Sunday, and they did manage to fix that 48-inch water main by 6 o'clock, and by noon, water pressure was starting to build. So we were 2.5 days of minimal water pressure in the county. So that's kind of where we were on a no-notice event and how we all responded together as the coalition. I can't say enough good things about my healthcare coalition, because as an emergency manager, if I tried to make all the phone calls myself to try and notify folks when something goes on, there's just not enough time and enough phones. So by calling my regional coordinating hospital, they start making phone calls for us. So I don't have to call every hospital. I don't have to call the dialysis centers. We have a communication line that gets that information out. And so it's a critical link for us as emergency managers to be able to get that information out, tell people what they expect should be happening, and then update them so that they get continued information on what the situation is and how things are going. So we really can't function very well without. I try and break down silos wherever I can and tell folks we really need to communicate, and the more we communicate and the more folks are in the loop, the better off we are, the better off we are able to resolve situations. So to kind of tie it all up, emergency management for me is a critical part of the healthcare coalition. We have to work together before an emergency so that we can meet each other and understand our roles to plan for, respond to, recover from, and mitigate large emergencies and disasters. We do not want to be handing out business cards on the scene of an emergency or a hospital evacuation and saying, hey, I'm your emergency manager, what can I do for you? We need to establish those lines of communication beforehand. How is information going to be disseminated? Who do you call? When should you call? For us, I'm a big advocate for, okay, this is happening. We don't need anything yet, but let's get prepared for. So if I have a school bus accident and I've got kids on the school bus, I'll call my coalition and say, I got 14 kids that are being assessed right now that may or may not need pediatric facility. Just giving you a heads up, as soon as I get patient conditions, I'll let you know, and you'll be hearing how many you're going to get or not get. But it gives them a little window beforehand so that they can start planning, whether they need to clear out a trauma bay or two, whether they need to stop elective surgeries, whether they need to set up triage, because as we all know, not everybody shows up in an ambulance. So that communication part is critical. Planning brings us together as partners and shows what resources we may have. You may have resources in healthcare that you don't know that are out there. Maybe it's a potable water source that they have water buffaloes. There's a lot of resources that are out there that we just need to be able to share, whether it's the mobile ambulance buses that can carry 13 to 15 critical patients on stretchers. There's a lot of different resources that when we work together and discuss, we find out we can help each other. So for me, working as a team allows EMA and the healthcare partners to collaborate, and we respond better together to meet the needs of the community and help each other out in times of large emergencies and disasters. So that is the end of my slideshow, and I just want to thank everybody for the opportunity to present and to kind of talk about our local healthcare coalition and why I'm so proud to be part of that healthcare coalition. Hand it back to Travis. Thank you.
Thank you, Susan. Sorry for the delay. Computer hung up for a second. All of you, thanks to all of you, all three presented three great perspectives on how emergency managers are our coordinators, but our healthcare coalitions make great liaisons to the rest of the healthcare infrastructure. I know through personal experience that when you have a large event going on, if you've got a bunch of hospitals or a bunch of healthcare partners trying to all call one emergency manager or one emergency management organization, they get overwhelmed very quickly because they have all of the other folks that they're trying to deal with to help respond to or recover from whatever the incident is. So if you can use or leverage your healthcare coalition as your liaison, it really does help provide better span of control, to use a word or a term that we're all very familiar with. Let's see if I can get this. All right, so we do have some questions already queued up in the box here. So I'm gonna see if I can pull one of these up. Melissa, do you want to take this one? I said it would be helpful to have a HICS training and certification, much like FEMA's, but specific to healthcare that coalition coordinators could teach and certify their partners on. Do you want to address that?
Sure, absolutely. I mean, again, we have most hospitals, I think, do use HICS, but not all. And we do certainly request that the coalitions receive appropriate training in NIMS. But if that's something that obviously the healthcare community feels strongly that there be a certification or a training curriculum around, we can certainly work with the HICS program, as we do have individuals that sit on the HICS committee about. Thank you.
While you're unmuted there, I'm going to throw another one toward you. Can you talk a little bit more about how private companies and organizations could play a part in healthcare coalitions?
Absolutely, certainly, and that's a great question. And we've had a number of coalitions engage large employers in their in their areas, everything from Fortune 500 companies to much smaller businesses. And some of them have obviously resources that can be brought to bear, but or healthcare volunteers, obviously, that can be brought to bear. But primarily, many sit on boards of coalitions solely to lend financial support and assistance, because they all recognize that if there's ever an emergency, whether that emergency occurs on their campus, their business campus, or whether it's something like a pandemic, we do have one Fortune 500 company that's highly engaged in their coalition, and they are so because they're concerned that if there's ever a pandemic or something that would take out a large portion of their workforce, they want to make sure that their employees get access to the best healthcare they possibly can so they can return to work as fast as possible from a business continuity standpoint. So we do have a number of private sector partners sitting on coalitions. And honestly, I always say and always like to remind everybody that most of healthcare in this country is private sector. It's not for profit or private sector, not in the public sector or funded by local or federal government. And I think it's critical that we work as a public-private partnership, both with government agencies and healthcare, but also, again, those private businesses. I know your question, though, was about private entities, but I also like to highlight this for everyone as well. If you have a DoD or VA type of healthcare facility in your community, we always highly encourage bringing them into your coalition and bringing them into your planning. Even though the federal government will certainly mount its own response if something happens to one of those entities, and it's not usually an emergency management problem per se, we always like to develop those partnerships in advance with those facilities, because they actually have a tremendous amount of resources that can be provided to the local community. They don't have to just stay inside the federal family. I'll give you an example of this. So during the last Ebola outbreak, we had one hospital that had a confirmed patient that didn't have a full complement of 21 days of personal protective equipment. And what few people understand is that through various different kinds of laws, the procurement and suppliers and distributors are required to fill DoD and VA orders before private sector orders. So as a result, the DoD and VA hospitals had more than enough PPE during the Ebola outbreak, and obviously the individual private sector hospitals did not. So this one hospital that did have a patient, an Ebola patient, wound up getting the vast majority of their PPE from the VA hospital that was just down the road from them. So again, while private sector partners are incredibly useful to have, don't forget about those federal public sector partners as well. Thanks.
Next question. Let's see if I can, sorry. How do you handle inquiries from entities about their level of involvement when they are spread across multiple counties, states, etc.? I'll open that up to any of the three panelists.
So this is Will. I would say we've got a couple of healthcare organizations in this state at varying different sizes and levels that have either management or facilities spread across a couple of states, and that involvement and that engagement really happens at that local level. That healthcare coalition that can reach out and touch those partners, that county that facility is in, that's really where that engagement starts and is focused. And certainly, I think you have the backstop at a state level of that agency or agencies to interface with that corporate management, or if there is a higher level outside of the state. I think that's how you can work some of those inquiries or support that's needed from our perspective.
Hey, Susan, did you want to add to that?
I did. So in the metro area, with the 8 counties, we do have multiple, let's just say, dialysis centers that have facilities in multiple counties where they might be in neighboring counties, they might be across, so some might be even in different healthcare coalitions. So what we always stress is be at your local healthcare coalition That's where you're going to get your best information for that particular facility, to be able to best get them involved at a local level, because everything starts locally.
Okay. That's both great, and I know from both perspectives, kind of some of the organizations you guys are talking about. And while you may be working with one group, the resources, their information sharing, the processes are all different as you go from locality to locality. There are several questions in here about whether or not the recordings and stuff are going to be available. I'll go ahead and address that now. The recordings will be available on our website, and I think that GoToWebinar will push actually a link to the recording back to you. We are working on the presentations. We'll get the presentations out to you as well. Susan, this question is for you. Do your healthcare partners collocate in your EOC during response, or do they have their own command center like an RHCC, a regional health coordination center?
So it honestly kind of depends on the event. So let's say it's the what I affectionately call the Clifton Corridor, where I have a children's hospital facility. I've got Emory University Hospital. I've got Emory University. I've got the CDC, and I've got several live, work, play communities. They have their own emergency preparedness group. So they actually have an emergency operations center there. If they open that emergency operations center, say for the Dalai Lama is coming to Emory University to speak, when they open that emergency operations center, I'll send a liaison from DeKalb Emergency Management over to them to help be our feet on the ground over there. And a lot of times we'll monitor from our emergency operations center as well, from a higher level, with police, fire, etc., so that we can assist and we are not actually too close to the actual event in case something happens. So some prefer to open their own facility, but we always encourage, especially in a large disaster, to have somebody with us in our emergency operations center, whether it's virtual, because they're watching our web EOC, which is our platform where we push out all our information and keep track of the event. Let's just say it's a ice storm. We have a road closure board on web EOC that we share with everybody. So all the healthcare facilities can look at that road closure board and see what's happening, even if they can't get to our EOC, if it's not safe to get here. So we are able to share both virtually and in person information when we have a disaster.
Okay. Will, this one is for you. Is the Trauma Center HPP agreement in North Carolina different from a more standard mutual aid agreement or MOU? And if so, how?
So I think short answer, yes, it is different. There is as a part of that contractual agreement, there is an MOU for the operational side of the house, and operationally what the healthcare coalitions are going to bring to bear during a response. That is included as a part of that contractual agreement, but the contract is a lot more robust than just a normal MOU or MOA. As we talk about transfer of federal funds, requirements or deliverables that the federal level or the state level may put onto the healthcare coalition to be able to implement for that year. So it's a little bit more robust. We can certainly work with our partners over at HPP here in North Carolina if it would be helpful to share some templates or some of those things, some of those agreements. We can certainly do that.
So we have, there's the contract, but then there's also the agreement, the hospital association agreement, correct?
Yes, and that's another one on top of that.
All right.
So what Travis is alluding to is our statewide healthcare association has helped sponsor and support a hospital emergency management MOU that hospitals statewide can sign on to, separate from the HPP program, that any hospital in the state can sign on to that helps facilitate resource sharing, equipment, all kinds of things. And again, we can reach out to those folks with our State Emergency Management Council as well and share those resources if that would be helpful.
Next question deals with home health agencies and ambulatory surgical centers. There's two questions on this. I'm going to try to summarize them into one. What's the best way to engage those kinds of organizations and include them in the process? Has anyone had success, or any of the three of you had success, or know of any keys to successfully incorporating home health and ambulatory surgical centers?
Hi.
So this is Melissa. Go ahead, Sue.
Sorry.
You go first.
I'll go from the local level. The coalition reached out and sent information out to try and engage specifically home health and ambulatory surgical centers, and invited them to our regional coalition meetings. Come see us, come talk to us, here's why it's important. And then from that, we then broke out them into separate groups. So we have separate meetings for hospitals and for the ambulatory surgery groups, and then for other groups, so that they don't feel like they're all meshed into one big group and that we're not hearing what their needs are, so that they can better talk to us. So we have other separate meetings as we classify these groups of healthcare agencies, so that I feel we get better face-to-face with them in these kinds of meetings, and then we better learn what they need and what we can assist them with.
Melissa?
I was just going to say, we often hear from a lot of coalitions around the country that when we're talking about including members, especially that many members beyond the 4 core, and with the amount of home care entities there are, agencies there are, ambulatory surgical centers, it can really become a lot. And we understand that a lot of the ways that coalitions have successfully managed and navigated having that many members is by using the association structure, or by using a lead entity, a lead home care or a lead ambulatory surgical center, who then kind of sits with the coalition and is really the one that's interfacing with the coalition, but they're bringing back any plans or planning efforts or critical information back to their individual members or their other types of colleagues, so that they're all somewhat represented, but it's just too hard to have meetings with hundreds of people at them. We all know that very little gets done when that happens.
Okay. Melissa, I think this next one's probably for you also. Is anyone aware of a database besides HRSA that provides information about healthcare entities in a particular county with their agency name, type, address, point of contact, etc.? There's concern there's not one resource that is current that we could have used to conduct outreach. Any suggestions?
Yeah, I suggest for sure that you contact your State Department of Health. All of them license those facilities, so they should certainly know where they are. The State Departments of Health are almost always, I think, and across all 50 states, contracted out by CMS to do the CMS surveys at the healthcare facilities. And if that is indeed the case for your state, like I said, they will certainly know just how many of them and where they're located and how to get in touch with them.
And I think this one is also a follow-up to your comment about the VA. Was there an obligation by the hospital receiving VA assets to return unused assets or repay the VA for those assets?
No, the VA commander of each institution is allowed to essentially take on civilian care, in other words, care for civilians in their hospital, or use their resources to provide civilian care, as long as obviously there are no veterans that are in need of that care. So in this case, because there were no veterans that had Ebola, or they weren't doing any rule outs in that hospital, they were able to just provide that to the hospital, and they did not indeed need to return it.
Awesome. And that's really the last question I have in the chat box. I want to take this opportunity to mention real quick from our partners at AHEPP, do a little advertising for them real quick. They do have their annual conference coming up November 4th through 6th in Orlando, Florida. Website is there at the bottom. Highly recommend going and checking this out. As an emergency manager, this is a great opportunity to, again, learn about what some of your healthcare emergency preparedness, emergency counterparts are doing. Additionally, we have, as part of the 2019 IAEM annual conference in Savannah, we have our 3rd annual Healthcare Emergency Managers Symposium. Again, this is not just for healthcare emergency managers. This is a day very much like this webinar for local emergency managers, state level emergency managers, healthcare emergency managers to come together for a full day and learn from each other, network with each other. There are 4 sessions throughout the day. Again, working with ASPR, AHEPP, we have a new group, the Academic Medical Center Emergency Management Consortium, so a lot of our large universities, and a couple other topics for the day. It's not your typical conference where you're talked to for 60 minutes and then you get 5 minutes to have questions. This is more designed to be a facilitated discussion where we're going to have a facilitator for each section introduce their topic or introduce their group. They're going to tell you some facts about what they do and how they do it. But then the rest of the time is all about conversation, learning from each other, sharing ideas, asking questions, networking together so that we walk away having learned something from each other. So that will be on the Sunday before the pre-conference, or the Sunday before the full conference. It is in beautiful Savannah, so it's a great opportunity just to take a trip to Savannah if you've never been. More information on registration for that is coming as IAEM launches their registration website. So keep a check on IAEM's webpage and all of our social media. With that, we will wrap up today's webinar. I want to say a huge thank you to Melissa, Susan, and Will, and all of the staff at IAEM for helping us bring this together and advertise it and share this information with you. I hope you found it beneficial. If you haven't connected with your healthcare coalition, please do so. If you have questions about doing it, if you don't know how to get a hold of them, if you have questions about what they can help you with, and you're not sure where to go, send us an email and we'll help you get in contact with the right people. If you have questions for Melissa, Susan, or Will, you can send them to iaem.health@gmail.com and we will get them forwarded on to them so we can get them answered. If you that way you don't have to remember several different email addresses. Again, we will be posting the presentations and recordings once they're available, and we will send you information on how to access those. And with that, I'll say thank you and happy Friday and have a wonderful weekend.